let's move on to hyperthyroidism. Hyperthyroidism is defined as a clinical state of elevated thyroid hormone action in tissues, usually due to inappropriately high constitutive secretion of thyroid hormone from the thyroid. The degree of severity of hyperthyroidism is typically divided into two groups. Overt is suppressed TSH levels with concomitant elevations in free T4 or T3, and subclinical is suppressed TSH with normal free T4 and T3. Both overt and subclinical hyperthyroidism can lead to clinically significant symptoms or signs, although subclinical disease is more likely to be milder in presentation. The clinical symptoms and signs of hyperthyroidism are broad, reflecting the fact that thyroid hormone exerts an effect on nearly every organ system. Overt hyperthyroidism can cause a litany of effects, including tremor, heat intolerance, tachycardia, and atrial fibrillation, increased GI motility, muscle weakness, anxiety, and embolic events. Uncontrolled hypothyroidism can rarely cause severe cardiovascular complications, including cardiomyopathy and congestive heart failure, that can even progress to cardiovascular collapse and death. Subclinical hypothyroidism typically has milder manifestations along the same disease symptomatology. The prevalence of hyperthyroidism in the United States is approximately 1.2%. The most common cause of hyperthyroidism is Graves' disease, toxic multinodular goiter, and solitary toxic adenoma, are all those in which thyroidectomy plays an important, if not primary, role in management. These three disease states are discussed in further detail below, and omidarin-induced thyrotoxicosis is also discussed below. Graves' disease, named after Dr. Robert J. Graves from the 1830s, is an autoimmune disease characterized by the constitutive activation of the TSH receptor by TSH receptor antibodies, which results in increased synthesis and secretion of thyroid hormone. Graves' disease is the most common cause of hyperthyroidism in the United States, with an estimated incidence of 30 cases per 100,000 persons per year. The disease has a female predominance with 8:1 female to male ratio, and typically presents during younger adult life with a typical patient age range of between 20 and 40 years. Because of its autoimmune etiology, Graves' disease can have other manifestations in addition to the classic symptoms and signs of hyperthyroidism. The most common is Graves' orbitopathy, which occurs in up to 25 to 30% of the patients. In this process, autoimmune reactions at the orbital and periorbital soft tissue leads to proptosis, eyelid retraction, chemosis, periorbital edema, and diminished ocular muscle motility. If left untreated, the orbitopathy can lead to vision loss from corneal lesions or optic nerve compression. Skin manifestations also can occur, including pretibial myxedema and acropathy, which is the edema at the digits. Other autoimmune conditions that have been associated with Graves' disease include Hashimoto thyroiditis, lupus, RA, pernicious anemia, and Addison's disease, among others. The biochemical workup for Graves' disease typically includes thyroid function tests, including TSH, free T4 and T3, as well as measurement of the TSH receptor antibody, typically with TSI but also with TSH receptor binding inhibitory immunoglobulin in selected scenarios. The presence of the TSH receptor antibody is diagnostic for Graves' disease. Imaging may consist of neck ultrasound and/or nuclear medicine thyroid optic scan, depending on the indications. The sonographic features may include a diffusely hypervascular gland, often with heterogeneous echogenicity. Thyroid nodular disease may also be identified. Nuclear scintigraphy using either technetium-99m pertechnetate or iodine-123 may help differentiate TSI-negative Graves' disease from toxic nodular disease based on diffuse versus nodular optic pattern. Cross-sectional imaging of the head may be useful for evaluation of orbitopathy. The three management options for Graves' hyperthyroidism include anti-thyroid medications, RAI ablation, and thyroidectomy. In the United States, RAI is the most commonly employed treatment option, although anti-thyroid medication is being used more frequently as a first option. Nearly one-third of patients may be able to achieve long-term remission with medication alone. In truth, each of the three treatment options comes with its own unique set of advantages and disadvantages, as well as indications and contraindications, which must be tailored according to individual patients' values and preferences. The 2016 American Thyroid Association guideline on the management of hyperthyroidism provides a helpful evidence-based summary on the clinical scenarios that would most favor a particular option for treatment. In general, thyroidectomy is the preferred modality in the following situations: presence of severe eye disease, failure or contraindication to other treatment options, need or desire for rapid reversal of hyperthyroidism, presence of concomitant suspicious thyroid nodules, large goiter with locally compressive symptoms, and pregnancy or postpartum or breastfeeding states. Although thyroidectomy is the first-line treatment option, in practice it is often relegated to a secondary role due to perceived risks associated with general anesthesia and surgery. For patients choosing surgical management, the recommended extent of surgery is a total or near total thyroidectomy, which is associated with nearly 0% risk of recurrent hyperthyroidism. In contrast, contrast, subtotal thyroidectomy is associated with a 5 to 10% risk of recurrence from the presence of residual thyroid tissue. Although the risk of thyroidectomy specific complications, including permanent hypoparathyroidism, recurrent laryngeal nerve injury, and neck hematoma, is higher in Graves' disease than for other indications, the absolute risks remain low, particularly in the hands of higher volume surgeons, and are no different between total or near total and subtotal thyroidectomy groups. The rate of permanent recurrent laryngeal nerve injury is 0 to 2%, permanent hypoparathyroidism is 0.6 to 6%, and neck hematoma is 0.3 to 0.7% for total thyroidectomy performed in the setting of Graves' disease. The risk of complications from remedial thyroidectomy is up to 10-fold higher than the initial thyroidectomy, which further underscores why subtotal thyroidectomy with its risk of recurrent disease is no longer favored. Preoperatively, patients should ideally be rendered euthyroid prior to or thyroidectomy with antithyroid medications. Typically today, this is methimazole, since PTU was found to be associated with liver failure resulting in the need of transplantation. Beta blockers may be added for patients who remain hyperthyroid and or tachycardic. High concentration potassium iodide solution, including Lugol solution for supersaturated potassium iodide, which can be given for 7 to 10 days prior to surgery. They are thought to be beneficial for decreasing thyroid blood flow and vascularity of the gland, as well as rapidly achieving a euthyroid state via the Wolff-Chaikow effect, although their use may not be needed in selected situations. All other associated medical and surgical comorbidities should be optimized. Lastly, preoperative optimization of calcium and vitamin D status, including preoperative supplementation with calcitriol, has been shown to decrease the postoperative risk of transient hypocalcemia. Thyroid storm is a rare state of life-threatening physiologic decompensation in patients with severe uncontrolled hyperthyroidism, which often occurs after an inciting stressor event, including thyroidectomy. The symptoms can be dramatic and severe, including fever, cardiac effects including hypertension, tachycardia, arrhythmia, and congestive heart failure. Mental status changes including agitation, stupor and coma, and hepatic failure. Treatment is multimodal and consists of beta blockers, antithyroid medications, potassium iodide, corticosteroids, mechanical cooling therapies, and intensive supportive care.